Welcome to our second episode in season 5 of ALKtALK. Thank you all for joining us during this early early time. Hopefully some of you are coming in from other time zones that can't usually be here. We try to do this every so often, and this actually worked out better for Dr. Lynn as well. So thank you for being here on this Sunday with us. Okay, so with us tonight, we have Dr. Jessica Lynn. She is an associate professor from the Harvard Medical School, and she is a thoracic oncologist at Massachusetts General Hospital. We are so excited to have her here. We lost out during the CrowdStrike of 2024 at the summit, and shows, one more thing that just isn't in our control, because we found that out when we got ALK. And then we were reminded that air travel doesn't always play into our favor. So a reminder, who am I? I'm Summer Farman, ALK-positive patient since 2020, Mark Rosenzweig's sidekick here, with lots of support behind the scenes from ALK-positive volunteers alongside with me. So let's start out with some polling questions. We'll see, everybody, how this goes. Oh, when were you diagnosed? And we were given some feedback that people wanted to have the option to have that half of a year in there. So you'll see it's under a year, 1 to 2 years, 2 to 3 years, 3 to 4, and so on. So again, that being said, also, as you complete this poll, we love feedback. So feel free to send feedback anytime to ALKtALK@alkpositive.org. You could send some compliments along with a wish. We like wishes too. But yes, so feel free to do that. Here we go with the poll. Yvonne, if you want to shout these out when I launch them, share results.
Okay, everyone. So when were you diagnosed? The biggest choice came in really around 20%, 2 to 3 years, followed by 1 to 2 years at 15%, 4 to 5 years at 12%, excuse me, 5 to 6 years at 9%. I'm now going out of order. My apologies. Under a year, we have 11%, 1 to 2 years, 15%. So really, we're crossing the entire gamut. I think the smallest group here is around 7 to 8 years, but also really nice to see 10 plus years, 8%, 8 to 9 years, also 4%. Great. So thank you.
Here we go. Treatment. What type of treatment are you receiving? Chemo and a TKI, alectinib, brigatinib. I can't take the poll, but that's me. Lorlatinib, chemo, a clinical trial, or no treatment.
This time I will just go in order just to avoid any complications. So chemo and TKI, we have about 4%. Those of us on alectinib, about 60%. Brigatinib, 11%. Lorlatinib, 18% of us on that one. Chemo, just 1%. 4% on a clinical trial, and 1% answered no current treatment.
Perfect. Thank you so much. Okay, and also here's one we haven't used in a while, but I'm really nosy and I'm scared to shift through and see who's here because I'm in charge of recording tonight. So let's see. What best describes you? Who is in the audience? Are you living with lung cancer? Are you a caregiver or family member? Or does something else bring you to ALKtALK, industry, or another connection? We're so grateful for all of you who are spending time with us, but we want to check it out and see who's here with us tonight. Thank you.
Okay, 89% of us in this call tonight are living with lung cancer. 11% of us are caregivers or a family member, and no one is joining us this evening from industry or another connection. So it's all in our community.
Thank you, Yvonne. Okay, also one last thing I wanted to let you know, stick around. for the entire talk. Dr. Lynn has lots of exciting things to share with us. And then she will be doing a Q&A, so you can put those in the chat right from the get-go, but we'll be holding off on answering most of those until later on. And then also, I have some things I want to share about upcoming ALK talks. Also some studies that are going on, patient preference studies, and some things on our Healing Arts calendar. So thank you so much, Dr. Lynn. Thank you for being here. Please take it away.
Thanks, Summer. Hi, everyone. It's so nice to see you. What a great turnout. And I recognize many of you in the audience, and I love to see your faces. I know this is at an earlier time than usual, so thanks for accommodating that. I'm going to share my screen here, and I was given the assignment of bringing ALK-specific relevant updates from the recent conferences that occurred, the World Lung Cancer Conference that happened in San Diego, and the ESMO Congress in Barcelona. Both were in September. And rather than just kind of flying through the slides of data from those conferences, what I'm going to do tonight is try to put the data in the context of kind of background information, how to fit those into how we think about the most updated treatment paradigm for ALK-positive lung cancer. And I'm sure some of the information here will be reviewed for many of you, but at the same time, I know that all of us come from different levels of background, so I wanted to make sure to cover that background as well. So how I'm going to structure today's talk is start with data that are relevant to thinking about the initial treatment when someone's newly diagnosed with metastatic ALK-positive lung cancer. So we'll share data relevant to that, and then we'll move into how to think about treatments in the subsequent setting, so later line, second line, or third line and beyond. Okay. So starting with the first line treatment, all of you know that we have multiple ALK inhibitors that are available in the United States. I've shown here the 5 ALK inhibitors that are approved in the United States, but also, I don't know if many of you know this, but in China, there are a few additional ones that are approved that we don't have in the United States. So I've listed them here as well, just because I know the ALK-positive community, it's an international community, and I think it behooves us to be aware of different pills that are available across other regions of the world as well. And we always use these terms, different generations of ALK pills. So we call crizotinib, which was the oldest pill for ALK that was developed. We call this first generation ALK inhibitor. And then we use the term second generation ALK inhibitor to refer to drugs like alectinib, which many of you are currently on today, and then brigatinib. And we use the term third generation ALK inhibitor to refer to lorlatinib. And this is a helpful classification because we think of each of these successive generations as having some advantages. So we think that the higher generation drugs have the advantages of not only offering increased potency and selectivity for ALK as a kinase target of the drug, but also improved ability to penetrate into the central nervous system, and also relevant to thinking about sequencing of treatment, increased coverage of different ALK mutations that can cause resistance to the earlier generation pills. And so when we think about the treatment paradigm that has evolved for metastatic or advanced stage ALK-positive lung cancer, until a few years ago, many patients would start when they're diagnosed with the first generation ALK inhibitor pill, crizotinib, and then go on to the second generation ALK inhibitor pill like alectinib, ceritinib, or brigatinib, and then go on to a third generation pill like lorlatinib. In fact, because patients are now living longer, as you know, we still have patients in our community who were diagnosed many years ago and did indeed start out with crizotinib as their first pill, did well for several years, and then went on to the next generation ALK pills. But today, in the recent years, when we have new diagnosis, the first ALK pill that is used is often either a second generation ALK pill like alectinib or third generation ALK pill like lorlatinib. And there are different large trials that supported that practice change. We're not going to review all of those trials today. We've done that before in other meetings. But what we're going to focus on is the data behind lorlatinib, which is the more recent data that's relevant, and which was also discussed again at the World Lung Conference and the ESMO conference. Okay. So I'm going to start with the data from actually the ASCO meeting, right? So the meeting that happened in June, where there was a 5-year follow-up update analysis presented from the CROWN trial. So just to walk through this systematically for everyone, remember that CROWN trial was the phase 3 trial where patients who had new diagnosis of advanced ALK-positive lung cancer and had not received any systemic treatment yet enrolled. And patients were randomized to receive either the 3rd-generation ALK inhibitor pill lorlatinib or the 1st-generation ALK inhibitor pill crizotinib. And the primary objective of the study was to assess the progression-free survival on these different treatments, but the trial also looked at other endpoints like response rate, CNS efficacy, safety, and so forth. And we already knew before the ASCO meeting that lorlatinib is a much better pill than crizotinib. But what was new at the ASCO meeting in June was that after 5 years of follow-up for this study, we saw that median progression-free survival for patients who were treated with lorlatinib as their first-line therapy was still not reached, meaning that the median progression-free survival on this pill, when it's used as the initial therapy, is going to be longer than 5 years, right? Because it's still not reached as of 5 years. And that's sort of the kind of level of efficacy that we have not yet seen with other ALK inhibitors in other trials, and really with other targeted therapies in lung cancer in general, even though we have many effective targeted therapy pills available. This is a slide that I had put together for the ASCO meeting where I discussed the 5-year update data with the audience. And what I tried to do here is try to contextualize how that level of efficacy compares to what we've seen with 2nd-generation ALK pills like alectinib, shown with the yellow bar here, and brigatinib, shown with the green bar here. The efficacy for lorlatinib is shown with the navy bar. And what this graph shows is what's the percentage of patients who are remaining progression-free, so continue to have good disease control at 1-year mark, 2-year mark, 3-year mark, and so forth. And remember, this is kind of comparing trials across trials. It's not there hasn't been a trial that has compared directly lorlatinib against alectinib or lorlatinib or brigatinib. So there are caveats to this, okay? But with those caveats in mind, you're seeing that as we march out after 3 years of follow-up, 4 years and 5 years, there does seem to be a difference that we're seeing with lorlatinib compared to the other ALK inhibitors, right? So with alectinib and brigatinib, the median PFS was around 30 to 35 months, with lorlatinib not yet reached at 60.2 months. And then if you look at 3-year PFS rates for alectinib and brigatinib, those are around 45 to 46%. But with lorlatinib, we have a 5-year estimated progression-free survival rate of 60%. So there is a clear difference here. And I would say the reason these data that were presented at the ASCO meeting were important is because there were some centers already before the ASCO meeting that were using lorlatinib as the preferred first therapy for patients that are newly diagnosed with metastatic ALK-positive lung cancer. But I would say since these data came along with a 5-year update at the ASCO meeting, there's a greater uptake of lorlatinib being used as initial therapy across the United States and globally as well. So we're seeing more of a shift in practice since these data came along. Another piece of data that was really important to see at the ASCO meeting was how does the CNS efficacy look with first-line use of lorlatinib? Now, again, we already knew lorlatinib is a very, very powerful drug in the brain against brain metastasis. It just penetrates that blood-brain barrier really effectively. In ALK-positive lung cancer, as you've heard before, that is an extremely important characteristic to consider for different ALK inhibitor pills, because we know that ALK-positive lung cancer likes to metastasize to the brain. And the frequency of brain metastasis here is far higher than we would like to see. And so what we need is a pill that's not only able to effectively treat the existing brain metastasis, but the goal would be to actually delay or prevent those brain mets from occurring in the first place. And this is what we're actually seeing with the first-line lorlatinib data from the CROWN trial. So on the right-hand side, what you're looking at is a curve that's showing the percentage of patients who are developing new brain progression after starting on lorlatinib therapy. That's the navy curve here. And red curve is for patients who started with crizotinib therapy. Let's not talk about the crizotinib data because that's now outdated at this point. We don't use crizotinib really for ALK-positive lung cancer. But if you look at the navy curve and look at the 60-month, meaning 5-year mark, 92% of patients do not develop any intracranial cancer progression after starting on lorlatinib. In fact, among patients who enrolled in this trial without any pre-existing brain metastasis, after 5 years, only 4 patients had gone on to develop brain metastasis in that 5-year timeframe, which is really something that's remarkable, very different from what we had seen historically with our patients with ALK-positive lung cancer, where at 5 years, we used to see a cumulative brain met incidence of exceeding 70%. And so that's a pretty significant advantage that we're talking about. I think one of the other factors that are influencing that treatment paradigm change with increased uptake of lorlatinib as first-line therapy for ALK-positive lung cancer is the knowledge that not all of our patients, not all of us that are progressing on the initial ALK inhibitor will see another ALK inhibitor therapy. And that's really unfortunate. And, it shouldn't be the case, right? With the existing ALK inhibitor pill options, everyone ideally who has cancer escape on a lower generation ALK inhibitor pill should then be able to get a higher generation pill like lorlatinib or 4th generation ALK pills in trials. But unfortunately, that's not what we see across the United States and globally. So these are global, not just United States, but global phase 3 trial data. So in the ALEX trial, that was the trial that looked at first-line alectinib versus crizotinib. And here, only 60% of patients went on to receive subsequent therapy after progression on the first ALK inhibitor. And similarly, in the ALTA-1L trial, which is the trial that compared brigatinib against crizotinib, again, similarly, 40% of patients did not receive subsequent therapy. And so this is part of the reason, not the only reason, but part of the reason why we use that paradigm of always using the best ALK inhibitor we have first, because we don't want to miss any subset of patients who are not going to be able to reach that subsequent therapy even when they are available. So now with that context in mind, we're going to move from the ASCO meeting to the World Lung and ESMO meetings, where there was further follow-up data and analysis presented on the CROWN trial. So already at the ASCO meeting, what was presented by Dr. Solomon and colleagues was that after 5 years follow-up, there weren't any new toxicity signals that were identified from initial lorlatinib therapy. So what this tornado plot is showing is the most common adverse events that are seen in patients treated with lorlatinib on the left-hand side with the blue shade. And so many of you have heard with lorlatinib, we see side effects like increase in lipid levels, we see neuropathy, we can see weight increase, constipation, mood and cognition issues. And that constellation of side effects didn't change in terms of the overall frequency or characteristics of the side effects. And when you looked across kind of the significant endpoints, like how many patients are having to come off therapy because of side effects, that remained low at 5%. And almost all of the patients who had to come off treatment because of side effects, it was within the first couple of years or so, as opposed to after 4 or 5 years, meaning that patients who were able to stay on treatment more than 2 years didn't really seem to have to come off treatment thereafter with new intolerable side effects. Then in San Diego, Dr. Bauer and colleagues presented kind of more granular data on what we're seeing in terms of impact on quality of life and side effects from lorlatinib therapy. And this is of great interest to our community, right? Because when you start on a drug like lorlatinib as the initial therapy, most likely you're going to be on this drug for several years. So one of the focuses was on hyperlipidemia, or increase in the cholesterol and triglyceride levels, because that is by far the most common side effect that we see with lorlatinib therapy. And what they showed was that in terms of management, 70% of patients who experience hyperlipidemia did need concomitant medications. And most commonly, what this is talking about is initiation on a drug like statin, right? And 20% didn't need any intervention. 5% did require dose interruption in addition to using a concomitant medication. And then 3% of patients did require dose reduction and dose interruption. So there was a small percentage of patients, around 4% or so, who did require dose modification of lorlatinib because of hyperlipidemia. But the vast majority were able to have this managed with initiation of lipid-lowering therapy, okay? Another really helpful aspect of data that was helpful that we saw was on CNS adverse events. So as you know, the neurologic adverse events with lorlatinib can manifest in different ways, and we sort of cluster them into categories like cognitive effects, mood effects, speech effects, and so forth. Again, the spectrum of different neurologic manifestations of adverse events didn't really change after a long 5-year follow-up. And so you're seeing that most of these were grade 1 in gray color, but there was some percentage that were grade 2 and grade 3. Now, when we talk about grades here in trials, you might wonder, what does that grade 1 to 4 mean? And what it's using is there's a certain criteria that we refer to for patients on clinical trials as sort of as objective measure as possible to quantify the degree of adverse event that the patients are experiencing. It's called CTCAE. That's abbreviated for some long name, like common terminology of adverse events and so forth. And grading basically is trying to capture the severity of the side effects. So here, for CNS adverse events, for example, grade 1 might be those that patients are experiencing, but it's not really impacting your activities of living, like your work life, your family life. Grade 2, that's already adult level where it's moderate, but it is starting to impact the work life and family life, right? So and then grade 3 is much more severe. And so I don't think we can neglect that there is a subset of patients, like 18% of patients who are experiencing grade 2 or higher neurologic adverse events. And the question is then, how can we try to ameliorate these side effects? And at lung, what we saw was that 58% of patients who are experiencing these CNS adverse events didn't require any pharmacological intervention. You might ask, what do pharmacological interventions mean? Most commonly, these would involve drugs like psychotropic medications. For example, if patients are experiencing mood issues, right, that are impacting their quality of living, they might need to have like a mood stabilizer or antidepressant initiated or dose modified. In this cohort, 60% of patients had their CNS adverse events resolved with dose modification or other management strategies. I would say that dose modification is generally highly effective in managing these side effects, including neurologic adverse events. And then 3% had to have permanent treatment discontinuation because of neurologic adverse events. The other side effect that was discussed was weight gain. And this is one of the side effects that I often discuss with my patients when they're initiating lorlatinib or when they're on lorlatinib therapy, because weight gain can be mild for some patients, but it can be significant for others. In fact, if you look at this graph here on the top left-hand corner, what this is showing is the frequency of grade 1 versus grade 2 in green versus grade 3 in blue weight gain experienced by patients treated with lorlatinib. So grade 1 is, what that means is 10% or less increase in weight from your baseline weight. So before you started on lorlatinib, right? And then grade 2 means 20%, so 10 to 20% increase in weight compared to your baseline weight. And then grade 3 is greater than 20%. So depending on what your baseline weight is, even grade 2 weight gain could be pretty bothersome, right? And could be stressful. So what they looked at here, they tried to look at what could correlate with weight gain. Do people that have higher baseline weight tend to gain more weight? That wasn't the case. When they did that analysis, baseline body weight, how heavy you were before you started on lorlatinib, didn't seem to influence the degree of subsequent weight gain. The other question that was asked, and I think this was a prudent one to ask, is there like a fair amount of overlap between patients experiencing weight gain and patients experiencing fluid retention or edema? Because that's another side effect of lorlatinib. And you can imagine if you're retaining fluid, that is going to lead to increase in weight. And there was a 40% overlap, but there was a fair subset of patients who who reported only edema, and a subset of patients who reported only weight gain without concurrent edema. So yes, fluid retention does contribute to the weight gain that patients are experiencing on lorlatinib, but it's not by any means the sole contributor. There are some metabolic changes that are happening, increase in appetite and so forth, that are also contributing to weight gain as well. And then they looked at how were these being managed by patients on this trial. 95% did not have any medical intervention for the side effect of weight gain. 2% of patients did require interruption of lorlatinib therapy because of this side effect, and 2% of patients required dose reduction only, 2% with dose reduction and dose interruption. So in total, 4% of patients required dose reduction because of the side effect of weight gain, and mostly the weight gain was managed with lifestyle modifications, like trying to be more and more active, trying to watch diet portions and the kinds of diet that were being consumed. So I think, we still need more insights going forward, but it's very, very nice and heartening to see these sorts of analysis being performed on these large trial data, because it's going to be critical in informing how we can try and address the symptoms as they come to improve the quality of life as much as possible. I always like to share this slide. This one was shown at the ASCO meeting, not at the World Lung meeting. But the reason I'm showing it again is because I think it's reassuring to see that dose reduction of lorlatinib, when it's required because of adverse events, doesn't seem to impact significantly the efficacy of the drug. So what this is looking at is it's looking at progression-free survival of patients who require dose reduction, and dose reduction is shown in the dotted line here. And the solid line is patients who require dose reduction. And if anything, the curve here is higher for patients that require dose reduction, meaning they were not progressing earlier because after the dose reduction took place. And the curve on the right is showing intracranial central nervous system metastasis progression. And again, there didn't seem to be a detrimental impact from dose reduction of lorlatinib therapy. So all the more reason to be aware of these side effects, to monitor for them, and to not be afraid of dose reduction if the side effects are significantly impacting your daily quality of life. So that is all on the CROWN trial. I did want to briefly mention this other trial that was presented as an oral abstract at the World Lung meeting. It's called Remark trial, and this one was a phase 3 trial that was performed in China. And it's again for patients who are newly diagnosed with metastatic ALK-positive lung cancer, so haven't received any other ALK inhibitor therapies, treatment naive. And the trial randomized patients to receive either foritinib, which is another tyrosine kinase inhibitor that targets ALK in addition to ROS1 actually, compared against crizotinib. I went back and forth about whether I should mention this trial to you or not tonight. The reason being that at the end of the day, I don't think that this pill will really be relevant to patients who are living in the United States, okay? It's not clear to me what place it has in the current existing treatment landscape for patients living in the United States. The only reason I'm mentioning it to you now is because it was an oral abstract discussion. I think it will be relevant to patients living in China. And some of you may come across this trial somewhere on the internet, or you may hear about it from other patients, and you may wonder, how come we've never heard about this trial? So I want you to just have the context of how I feel about this trial, and I'll give you the bottom line, okay? So this trial, again, foritinib is shown on the red color, crizotinib, the control intervention, is showing on the blue, and this is showing the progression-free survival. Foritinib was better than crizotinib in terms of progression-free survival. There was a 77% risk reduction in terms of disease progression or death. And we don't have a median progression-free survival yet. Follow-up hasn't been long enough for itinib arm. It was also active in the brain. So this curve actually looks really good. It reminds us of the curve that we saw with lorlatinib, where it was pretty much a flat curve for CNS progression with first-line lorlatinib in the CROWN trial. It's basically, we're seeing the same thing here with foritinib pill. It's a good drug in the brain. This is the overall survival curve. So how long are patients living? And basically, it's immature data. They don't have long enough follow-up for this trial to make any firm conclusions yet. Side effects, how is this pill tolerated? It's a little bit of a unique side effect profile. So you can see here, foritinib, this is showing grade 3, so pretty severe treatment-related adverse events. And at the top is hyperglycemia, increase in sugar levels, and grade 3 or higher in 11% of patients. When they say grade 3 or higher hyperglycemia, that means your sugar level is so elevated that you are needing to start on insulin injection therapy or needing to be hospitalized. So that's a pretty high impact. And it's not a common side effect that we see across ALK inhibitors. So that made me do a literature search to learn a little bit more about foritinib as a pill. And I wonder if there are kinases outside of ALK and ROS1 that are being impacted by this pill at this concentration that's being given, where a side effect like impact on sugar level can transpire. And then same thing like lymphocyte count decrease and neutrophil count decrease. We don't often see these kinds of issues with ALK inhibitors. So I think we need more granularity on the safety data for this pill. And there are some things that I'm seeing that make me think that there are other non-ALK ROS1 targets. So the bottom line for this pill, foritinib, we will probably hear more about it for patients in China. So now you know what it is and what was the trial that was done to show the efficacy in patients with ALK-positive lung cancer. For me, in the United States, it doesn't have a clear place based on the data that I'm seeing, okay? So that is the section on the first-line treatment. Now I'm going to spend the remainder of the time discussing the data relevant to later-line therapy after the first ALK inhibitor was used. And again, let me first contextualize things and provide just a little bit of the background. Many of you said you are still on alectinib therapy, right? And there are some of you on brigatinib therapy. So many of you are on this second-generation ALK inhibitor. And one of the questions at the top of our minds is, what happens once cancer gets worse on the current pill? What do we do? And there we know that in about half of the time, when cancer gets worse on alectinib or brigatinib, it's because there are new ALK mutations that are causing that resistance. And these pie charts are showing different ALK mutations that we have detected in samples from patients progressing on a second-generation ALK pill like alectinib or brigatinib. So the most common ALK mutation that we see is this G1202R substitution in ALK. We also see mutations like I1171 substitution in patients progressing on alectinib. For each of these mutations, lorlatinib does have potency. Lorlatinib is able to effectively cover those mutations that confer resistance to alectinib and brigatinib. And consistent with that, in patients who are having cancer escape on those pills, we've seen lorlatinib, again, reinduce cancer shrinkage. So it's shown a good response rate. In median duration of response is about 7 months. And what these graphs are basically showing, the bottom line is that if your cancer is known to have a specific ALK resistance mutation that can account for the cancer progression on a pill like alectinib or brigatinib, then there is a significantly higher likelihood that switching to lorlatinib as subsequent therapy will indeed help you. Okay, so if you get a rebiopsy after cancer progression on alectinib or brigatinib and it shows an acquired ALK resistance mutation like G1202R, we can be fairly confident that lorlatinib will be an effective next-line strategy. One of the key challenges that we have been trying to address in the recent years is it's great to have lorlatinib as a possible option after alectinib or brigatinib. But what do we do for patients then after their cancer progresses on lorlatinib? What other options can we have? As many of you know, after lorlatinib, we don't have other fourth-generation ALK inhibitors that are currently FDA approved. So that was a big existing gap. To address that gap, groups multiple groups at institutions looked into what are we learning from samples from patients who are progressing on lorlatinib. These are data from Mass General, and what we saw was that in about 30% of patients who have cancer escape on a pill like lorlatinib, there are newer ALK mutations, multiple ALK mutations occurring together that are causing that cancer escape. And that really motivated the development of fourth generation ALK pills that are able to cover effectively for these compound ALK mutations that are refractory to lorlatinib therapy. Many of you have heard about ALKOVE-1 trial, which is looking at one such fourth generation ALK inhibitor called NVL-655 from the Nuvalent company called Nuvalent. And I wanted to talk a little bit about this trial today because the data were presented at the ESMO meeting in Barcelona just 2-3 weeks ago. So we had initially presented some preliminary efficacy and safety data for this pill last year. But this past September, we updated that presentation with a significantly larger number of patients at this point that have enrolled in this trial. So just to orient you, ALKOVE-1 is a clinical trial that as of these data had enrolled patients who had received at least one prior ALK inhibitor. So these are not newly diagnosed ALK-positive lung cancer. These are not patients with newly diagnosed ALK-positive lung cancer. And you can see here the number of patients that were treated as of the data cutoff. So over 100 patients, which is a pretty large number. The trial started enrolling patients at a very low dose level, 15 milligrams once a day. And then there was a gradual escalation of the dosing after we made sure that the dose was safe to higher dose levels, as you can see in this table. This is a busy table, but basically the high level key points are that most of the patients that you're seeing in the upcoming slides had non-small cell lung cancer. There were a couple patients who had other tumor types. You can see here over half of the patients enrolled in this trial had a history of brain metastasis. And so that, I would say, is a good capture of our ALK-positive patient community in general. Some of these patients had ALK mutations, including compound ALK mutations that we know can be refractory to lorlatinib. Patients had received a lot of prior ALK therapies or other cancer therapies. So you can see here, over 60% of patients had received 3 or more prior lines of treatment. 46% of patients had received 3 or more prior ALK inhibitors. 84% of patients had received lorlatinib previously. Okay, so this is really speaking to that exact niche where there was a need for new treatment to be developed. This is what we call the waterfall plot, which aims at summarizing the efficacy data that's available thus far. So each bar, I know many of you are already familiar with this, but just in case some of you aren't, each bar is basically representing a patient who generously participated in this trial. And how low the bar goes is showing how much the tumor shrank. So the lower it goes, the more shrinkage there was. In fact, these first 2 patients had 100% shrinkage of the tumor, right? But on the far left, what you're seeing is there were some patients who had growth of their tumor. So this patient on the far left had 60% increase in the size of the tumor compared to their baseline. So again, we don't have to go into this in detail today, but from a high level, what you can see is most of the patients have the bars going down, right? Meaning most of the patients did benefit from this pill, with some good subset of patients having a pretty significant shrinkage in the tumor size. If you look at patients who had known ALK mutations when they enrolled in this trial, over 50% of patients had significant shrinkage of their tumor. This is looking at subsets of patients. So if in patients who had received prior lorlatinib, 35% of patients had significant shrinkage. Now, if you ask, what do you mean by significant shrinkage? That means there's a higher percentage of patients who did benefit from this drug in terms of stabilization of the cancer. These percentages are just speaking to those patients who had noticeable decrease in the size of their cancer. So these are really encouraging data for a population of patients where there are no other approved targeted therapy options. This drug is also showing promising CNS activity. So we're seeing patients, including those who had progression on lorlatinib, have brain metastasis respond to NVL-655 on this trial, which was, again, also very exciting to see because we always need more options for patients who have active brain metastasis. And this is another key slide. So when NVL-655 was developed, it was intentionally developed not only to be powerful against ALK, not only to cover different ALK resistance mutations, not only to penetrate the brain, but also to be really selective against ALK and to not affect some of the other non-desirable kinases like TRK protein. We know that for some of the existing targeted therapies, they also affect TRK protein, and that leads to neurocognitive side effects like mood or cognition changes. And TRK inhibition can also cause dizziness, balance issues, change in the way the food tastes, and weight gain as well. And so this particular pill was intentionally developed to try and spare those TRK proteins as much as possible. And what these preliminary safety data from the ESMO Congress are showing is that what's being seen in patients who are treated in this trial really does speak to that design of the ALK selective ALK inhibitor. We are not really seeing much in the way of neurologic side effects so far. There have been some liver enzyme increases that have been seen, as you can see here, some constipation, some nausea, a little bit of change in the way foods taste, but overall, a favorable profile. So from a safety profile perspective, also very encouraging data that we saw at ESMO. So this trial is continuing to enroll patients, as all of you know. And then there's a phase 3 clinical trial planned as well for NVL-655. Okay, I want to make sure to save time for Q&A because what I can see is that there are 21 chats, but I cannot see them right now because I'm talking. So what I'll do is I'll go through the remaining slides fairly quickly, and we can always come back to them later, or I can come back to another ALK talk, which I'm always happy to do. I just want to briefly touch on the fact that compound ALK mutations we see in patients who received a drug like alectinib or brigatinib, then lorlatinib, and then have cancer progression. It's not clear how much of that we'll see in patients who are starting out with lorlatinib as their first therapy. Indeed, if you ask me, Dr. Lin, what are we going to see in terms of resistance mechanisms when patients receive lorlatinib upfront and then cancer gets worse? And of course, we care about that answer because it informs how we think about subsequent treatment options. It's very much, there's really limited data there so far, and we really need longer follow-up of the CROWN trial data to inform that. The reason being that most of the patients who have been on the CROWN trial are still doing well on lorlatinib therapy. There was some early data that were presented at the ASCO meeting this year, where in 31 lorlatinib-resistant biopsies that were analyzed, there weren't any ALK mutations that were picked up. And what that suggests is that in most cases, after first-line use of lorlatinib, there's going to be non-ALK-driven mechanism of resistance. And so we need to follow up on that further. We did see some data at the World Lung meeting presented by Dr. Tony Mock and colleagues in September, where they did further analysis of, well, when patients are having cancer get worse on first-line lorlatinib or have to come off lorlatinib for any reason, what kinds of treatments are they receiving? And how are they responding to those subsequent therapies? I certainly care a lot about those data, and so I was really happy to see it presented. And what we saw was that so far, 38 patients had received subsequent therapy after first-line use of lorlatinib in the CROWN trial. This is the number of therapies received. So most of the patients had received only one subsequent anti-cancer therapy. This table, I'll kind of walk you through it. 61% of those 38 patients received another ALK inhibitor after lorlatinib. About half of the patients received alectinib as subsequent therapy. Some patients received ceritinib, crizotinib, brigatinib, and then there was about a third of patients who received chemotherapy-based regimens. And I think it'll be good to see more granular data on who exactly these patients are who received alectinib, like what was their resistance mechanism that was identified before they went on alectinib. I think that will be informative in interpreting this data. But certainly good to see that patients are having some good months of therapy on the subsequent regimen. So this is the duration of therapy on the first subsequent anti-cancer treatment was 9 months. And actually for patients who went on another ALK inhibitor after first-line lorlatinib, the median duration of therapy was about a year. So this is an area where I'm looking forward to seeing more updates presented in the coming years. So why don't I stop there? Because I want to make sure we get to some of the questions from you.
That was so fabulous. Thank you so much. That was a little bit of everything, but like with a great deep dive into it too. So that was so awesome. Thank you so much. We've gone through also and tried to, we can go through the chat, but also summarize some of them. The
Yes.
big thing that we're all in a panic about, not really, but shocking for us to hear is that data saying 30 to 40% of people in the US even and globally never make it to second line therapy. So yeah, so there was all sorts of questions in there about saying like, if I've been on this for 5 years, where am I going? Or what do you think? What's some insight into that? What's your take on that exactly?
Yeah, that's a great question. I'm glad it was asked. If you've been on a pill like alectinib or brigatinib for several years and you're doing well, my recommendation, bottom line, I wouldn't change. The reason is that whenever we're trying to make treatment recommendations and going off of clinical trial data, we're going off of statistics for patients that enrolled in those trials who weren't you. You're you. And if we know that you've been on alectinib, let's say for 5 years, and the cancer is behaving, that is the best piece of evidence and data we can have about the biology of your personal own cancer. That is data that tells us that your cancer is very sensitive to alectinib, that alectinib is a very good pill. And so I would not recommend rocking the boat at that stage and changing to lorlatinib therapy.
But why do you think, and again, I know that you might not have insight into this, but then what is that data saying? But 40% of you that have been on, let's say, alectinib for 4 years or whatever TKI on this first line treatment won't get an opportunity for a second line. Like what?
Yeah, so remember, those are global trials. So it's not all data from the United States, but that said, a subset of patients, even in the United States, will not get second therapy. And some of that, I think, does have to do with the unfortunate cases where cancer may progress really, really aggressively and rapidly to the point where your body gets just so weak and sick and there's not enough time for the other treatment to be initiated. Now, that can be jarring to hear, but that is exactly why we do regular scans faithfully on a surveillance schedule. And that is why we always encourage patients to call us if you're having some symptom that is not fleeting. Like if you're having a symptom that comes on and is staying for like a week and it's not abating or it's continuing to get worse, you definitely want to call your doctor so that the scans can be moved up if warranted, instead of just waiting for that regular appointment to happen.
Perfect. That so many great points with that. And then two, then you're biopsying if you can, right? It's not just a linear sequence. Somebody said, well, what would I go on next? But it's not just we follow in a row.
It's an important point.
Mm-hmm.
It's a positive thing that we have more than one treatment option to think about. It's not like we're locked into one possible next treatment option that you must commit to, no matter whether we think it's likely it's going to help you or not. So it's a positive thing, but it's also a negative thing because exactly like you said, it makes things more confusing and it's not a clear, simple one pathway. I always recommend biopsies whenever cancer is changing. Sometimes tumor biopsies where they do like a long nodule biopsy or adrenal biopsy or liver biopsy, sometimes it's just not possible. For example, if the cancer spot is too small for biopsy, sometimes if it's in an area of the body where it would not be safe or advisable to attempt biopsy. So tumor biopsies are not always possible. In my practice, I try to do paired liquid blood biopsies and tumor biopsies because they can offer complementary information. And so even if tumor biopsy is not possible, I would at minimum try to ask the doctor to send off a blood biopsy. Blood biopsies have their own limitations. It's not always going to come back showing something, but it's a couple vials of blood, and I tend to think that if it's going to end up being helpful, you have more to gain than lose. So that's why I always try to recommend paired liquid blood biopsies and tumor biopsies.
No, that is great. And also for more information on that, if you're wondering, our ALK 101 series, episode 4, I'm progressing now what? You can also go back to YouTube and look those over, and it talks more about what Dr. Lynn is saying. So that, and then also your point about your first move is your best move. So there was another question in there about, well, what if I am newly diagnosed and was put on alectinib? Like, should I seek a second opinion for myself or one mentioned their child? What would you suggest with that, with the data we have?
Yeah. So if it's very, very recent, I might think about getting a second opinion. Again, it all depends on I don't know, like I'm not privy to all the prior history and whatnot, but and there's no golden rule. Like there's no rule that says, oh, if you are diagnosed within so and so however many months or however many years, that means you have to switch. There's no golden rule like that, right? It's a data-free zone. And any ALK specialist that you speak to even may have different thoughts on that. But I would say if it's a fairly recent thing, certainly if it was within 6 months or so, it's worth at least having a discussion about the possibility of switching versus staying on alectinib.
That is great. Yvonne, anything jumping out to you that you want to touch on? Oh, you're on mute.
Sorry, I thought I hit that button. There we go. Thank you so much. Thank you for all this. And I think I also just had some general questions about the CROWN data that you presented, which is really, it's frankly looks quite amazing. I think some of the things you're touching upon are also, things we need to think about and questions in our patient population, like the weight gain in particular, some of the adverse events that are quite serious. And it brings a couple of questions to mind. Number one, the guidance seems to be to start on 100 milligrams in many parts of the world. In the UK, they're more fixed on these things, although lorlatinib first line's not yet approved here. But what do you think about starting dose, and how would you best stratify those patients? Do you think about they have brain mets or they've had prior maybe mental health issues? Like, is there anything that would help determine the best dose to put someone on?
It's a very difficult question. My short answer is my default is still to start with 100 milligram once a day dose, the FDA label dose. One of the reasons being that we've learned that we are terrible at predicting which patients are going to have a tough time with a pill versus not, and how. There are some patients where we might worry very, very much about certain side effects of the drug, and then they end up flying through. And then we have patients where we think they're probably not gonna have any major issues, and they have a really tough time with the pills. So because of that, the only way for us to know for sure is to try and see how things go. And my rule of thumb is to kind of have a really lengthy, extensive talk about things to watch out for, so that we can hold the drug and lower the dose if that's appropriate. Now, if somebody has a really extensive psychiatric history and just like any small risk of significant mood or neurocognitive issues cannot be tolerated, I think that would be one such scenario where I might consider starting with a lower dose.
Thank you for that. And I guess following on the same track, it's also can be terrifying, exhausting, like going to the latest inhibitor and then thinking about what are my options. We'd like to have plans A, B, and C. Thank you for sharing the data you were sharing and how they're now going back to the other ALK inhibitors or chemo to re-challenge. But I guess we're always trying to think about how can you get the max out of all the drugs available to us. So I don't know it seems like you're saying it's too early, but is there anything more that should be guiding these discussions? It's also really hard for a patient in this new shared decision-making era to get involved in those discussions in the first line setting. These are very complicated discussions. So I don't know how you also guide patients going into this in a first line setting.
Yeah, I agree. I think, I think when the Crown trial data were presented for the very first time, when the follow-up was only about 18, 19 months or so, so much shorter than 5 years, there was definitely a lot of, we have no idea which one's going to end up being the better way to start, whether it's with lorlatinib or second generation ALK. And I think now that we've seen the 5-year follow-up data, I personally, my own practice is I actually recommend lorlatinib as the first pill. It's no longer like, oh, we have 2 great options or 3 great options, alectinib, brigatinib, and lorlatinib. Let's talk about why, whether we want to start with one versus the other. It's not like that. I think for me, the discussion has shifted to my recommendation because of these reasons is to start with lorlatinib. So unless there's a reason to not do that, like a contraindication to doing that, that would be how I would have the conversation. Of course, it's a shared decision making in the sense that, as with any pill, you have to be okay with the recommendation and whatnot, right? So I take that into account. But I think it's also our job as oncologists to just be, because of all the things that you said, Yvonne, to try and break down all the complex data and think, if it were my family member, what would I recommend, right? And so that's what I try to do when I have these conversations.
That's really helpful. Thank you. I also see a question here, and it's also one of my own, and we hear people asking this question about what about GLP-1 inhibitor and agonists like to manage the weight gain issue? What are the views on that at the moment?
Yeah. I actually talk about it with my patients, and I think the tough thing is there's no great guideline on if the use of those drugs should be different for patients who are having these side effects from TKI. So certainly if you have an indication, FDA approved indication for a GLP-1 agonist, like a BMI after a certain threshold or other coexisting conditions, I am all for trying a GLP-1 agonist if needed. You just have to meet an indication for it.
And just to clarify what that is, it is
Ozempic, Wegovy, all those.
I was just
Sorry,
right.
I was trying not to use the brand names, but it's hard
I
to.
know, but it's
Yeah, just so everyone understands what we are talking about.
thank you.
Liraglutide, and usually it's not oncologists who would prescribe these medications. So it would be a kind of collaborative multidisciplinary discussion between your oncologist and cardiologist or primary care doctor even, or endocrinologist. So it becomes very much a teamwork there.
Wonderful. I see a question in the chat from one of our community members asking about psychotropics, which ones are best for nerve pain and neurological effects from lorlatinib in your experience?
Yeah, it's different for everyone. I think for neuropathic pain, when medications are required, often the first ones that we reach for is a drug like gabapentin or pregabalin. When there are concomitant mood issues, if you're having more anxiety or depression issues, another good option to consider is a drug like duloxetine, because that has effect on neuropathy as well as mood. But when it comes to neuropathic medications or mood medications, it becomes much more of a granular discussion based on what you're experiencing and your personal treatment history. And so that definitely has to be more of an individualized conversation with your doctor.
Wonderful. Someone else in the chat was asking about the comparator. Why are we always using crizotinib as a comparator? And actually at ESMO, I heard Dr. Alex Dreeland talk about that in NVL 655, the Nuvalent trial. They're going to do evidently a head-to-head against alectinib, which will be very interesting. But why are people still comparing drugs against crizotinib in this day and age?
They shouldn't be. Yeah. The reason Crown trial used crizotinib as the comparator was because when it was launched, in many parts of the world still, the alectinib or second generation ALK inhibitor was not considered standard first-line therapy because it was launched many years ago. But for the trial that I just discussed that was presented at the World Lung Meeting, that one was launched several years later. So I agree. The ideal control arm should not have been crizotinib.
That's good to know. Thank you so much.
And we want to be respectful of your time. But so thank you so much. Just one little question with the dosing, and that everyone too, like these are recorded. Feel free, if you don't have these conversations with your oncologist, that you could recommend, you can send the YouTube along to them. There's so much new data coming out all the time, and it's great for them to hear from experts in this area too. If this isn't, thoracic oncology maybe isn't their specialty, but dosing, for example, as well, you need to be an advocate for yourself. And dosing, Dr. Lynn, there were a couple questions. Do you usually start high and go down? Do you like to, people were saying, why not start low and go up? What do you seem to find best practice?
Usually the default is to start at the approved dose and go down if needed. Sometimes I do start at a lower dose and go up, but I would say the default is the former. Because that way, again, because we're terrible at predicting, that way we know how your body personally handles the medication at the dose higher. And so if we know it's not tolerated, then we can jettison that dose and go down.
Yes. Okay. That makes so much sense. Thank you so much for joining us. Everybody stick around. We do have some announcements, but I don't want to keep you, Dr. Lynn. So thank you so much for your time. I'm so glad this worked out and we were able to have you here tonight.
Thank you so much for having me. It was really wonderful to see all of you here, and hopefully I'll see you again at a next opportunity soon.
Thank you, Dr. Lynn.
Thank you, Dr. Lynn.
Dr.
Thank you, Dr. Lynn.
Thank
you so much.
Dr. Lynn.
Thank you, Dr. Lynn.
Thank you, Dr. Lynn.
Thank you.
Thank you.
Thank you,
Thank you,
Dr.
Dr.
Lynn.
Thank you.
Thank you.